Can meet. Good morning, everyone. Thank you for the people who are coming already. The second day of number 6. We're going to start with a lecture with Professor Anne-Marie Lenon, whose father's name is John Lennon, like another John Lennon, who's the director of the Johns Hopkins Division of Gastroenterology and Anthropology, professor also of medicine at St. Vitus University with special interest of pancreatic lesions and early detection of cancer. She's going to talk about the very innovative and novel technique of probably detection and maybe even targeted treatment of cancers, which is lichen biases. Floor is yours.
Thank you very much. So it is a pleasure and an honor to be here and to hear my disclosures on it. In 2023, 18.1 million people around the world are going to be diagnosed with the cancer. Out of those, 10 million will die from the disease. So how can we change this? And then because gastroenterology clinic allows us to talk about removing early cancers, detecting early cancers, but ultimately we need to have somebody send us the patient so that they can pick up those early cancers. So what is the answer to it? And it's to detect cancer earlier. I think we all know that. But what's the actual data? And this is the data here. They differently in green, you have patients with distant metastatic disease. In blue, you have patients with regional disease. And in purple, you've got the earlier stage, people can look like Steve. And here's the 5 years of dialogue. And what you can see very clearly is the earlier you detect patients with multiple cancers, whether it's pancreatic cancer, esophageal cancer, you can detect patients early enough, localized and regional disease, then cancer is curable. So we actually have 4 tests to screen cancer. We have breast cancer or rectal cancer. We can speak of breast cancer, the colorectal, which of course we all know about, cervical and lung. But less than 20% of all of those cancers that we spoke about can be detected with these screening tools. And over 2/3 of cancer-related deaths occur in types of cancers for which there is no screening test. So what are liquid biopsies and how can they help? So liquid biopsies are the way you call blood test. And then when you didn't look at it, if you take a blood test, we have to look at circulating tumor DNA. So the cancer cell releases DNA into the bloodstream. And this can be counting of the technology to detect it. And these tests are now available in the United States and you can be coming around the world. And what I'm going to talk about here is when your patients come in and say to you, doctor, I want a liquid biopsy, you'll be able to tell them how good is it, what can we do with it, what are the pros and cons, to right, so we use this. So start relating to DNA. We all know pancreatic cancer. All pancreatic cancers have a KRAS mutation. So perhaps you can use this to detect pancreatic cancer. And the answer is we can. Just keep these here. There are multiple different types of cancers which can be detected with the blood test for KRAS. But if you look for carefully, you can see the red bars are patients who've got early intentionally cure on the cancer. And the orange bars are people with the metastasis. And when you see it up at pancreatic cancer, the blood test is very good at detecting metastatic disease.
But we don't want that. That's of no importance. What we want to do is detect early, potentially curable cancers or curable esophageal cancer so we can come, send it to our endoscopist and resect it. But what you see here is that it's not as good as detecting early cancer. And so using circulating tumor DNA alone is not good enough. And you need to combine it with other markers. So there are several different ways of doing this. So we just talked about mutations. You could combine it with cancer proteins, for example, CA19-9. We all know about that. And you can also try looking at other markers such as methylation, aneuploidies or abnormal chromosome levels, or other metabolites. But I want to share with you, I think, the first study that was published in liquid biopsies. And this is it here. So in this study, this was a test that was developed to identify these 8 common cancers, many of which we as gastroenterologists are interested in. Cancer of the esophagus, cancer of the stomach, colon cancer, liver, pancreas, and it also was designed to detect lung cancer, breast cancer, ovarian cancer. So does it work? Well, this is a retrospective study, but it's large, and just over 1,000 patients with one of these 8 different types of cancers. And what you can see is it was able to detect all the different types of cancers, but its ability depended on what type of cancer you had. So it picked up 34% of the breast cancers, up to 98% of the cancers for patients with liver cancer. And the overall sensitivity for all 8 cancers was 59%. Very importantly, with 99% specificity. Why do I care about the specificity? Because if you drop below that level, you're going to have too many false positives and you can't screen for it. And again, the concept of this is, here we all are in this room. As far as we know, we hope none of us have cancer. But of course, we all know that that's not necessarily the case. And so this is the idea of this is you're walking down the street and you're screening for people who've got no symptoms and who, as far as they know, don't have cancer. So I suspect that the next question you're going to ask me is, that's great, but I just showed you a study where all of the cancers that were detected were late-stage cancers, which is of no use. So can we now detect early cancers with liquid biopsies? And the answer is yes, we can. It's good, but it's not perfect. So as you can see here, it's easier to detect advanced cancer. Almost 80% of the patients with stage 3 cancer were detected. But we still were able to detect 43 to 73% of patients with stage 1 and stage 2. And we're seeing this not only with this marker called CancerSeq, which looks at combining mutations and protein markers, but also with a test called Gallieri, which looks at methylation. And so we're now getting increasing data that you can pick up early cancers through a liquid biopsy. But I suspect that our panel over here are going to highlight a couple of issues with these studies. They're probably going to tell me that, hey, all of those patients had cancer, and therefore these are probably larger and more advanced, and you're going to overestimate sensitivity. If you read them carefully, that you'll see that the controls were often younger, and they may not have relevant comorbidities, and therefore the specificity may have been overestimated. And what's the risk of doing unnecessary harm? What's the risk that you have your patient has a liquid biopsy and decides they don't need their colonoscopy if it's negative? And what's the risk of having invasive, futile procedures? So this study is the only prospective interventional study that's been published to date, and it tried to answer some of those questions. So it looked at 10,000 women aged between 65 to 75 with no history of cancer. So did it work? And the answer is yes. They were able to detect not only those 8 cancers for which it was developed, but also other cancers such as thyroid cancer, lymphoma, appendiceal, uterine, and kidney cancer. And this is what you would expect, because these markers detect multiple different types of cancers, not just a single one. So overall, there were 96 cancers detected, which is what you would expect from looking at screening for cancer in this age group. 24 were detected with our current screening tools, mammography, colonoscopy, low-dose CT. 26 were detected with the blood test, and 46 patients presented with symptoms. So the use of liquid biopsies doubles the number of cancers that we can detect compared to using current screening alone. So what about the stage? Were these all late stage, incurable, or early stage? And 62% of them were localized or regional disease, so potentially curable. This study was published in 2020, but we're now 4 years on from when the first patients were enrolled, and we now have long-term follow-up. Because you may say to me, that's great, you're picking the cancer up, but do you actually make a difference in their outcome? Maybe they all die from cancer and all you're doing is picking it up early, so lead time bias. And the answer is, so here we are 4.5 years later. So 100% of the patients with stage 1 and stage 2 cancer are in remission. More than half the patients with stage 3 cancer are alive, and of those, 60% are cancer-free. Just over half the patients underwent surgical resection, and of those patients, 86% of those are alive and cancer-free. So we can now when you see your patient and they say, hey, should I have a liquid biopsy? And if so, what does it mean and how good is it? You can say there's now data in a prospective interventional study in 10,000 individuals, which shows that you can detect cancers, you can detect early cancers, and if you send patients to surgery, that this can lead to surgery with long-term cure. So I think one of the big worries with liquid biopsies are, what's the risk for harm? What's the risk for having a positive test? And then we fill up, the NHS and all of us are filled with doing multiple different tests looking for where the cancer is. So overall, in 10,000 women, 1% of them had a false positive test. And of those 100 patients, 62% had no further tests. 16% went on to have non-invasive follow-up. For example, if you had a lung nodule, they went for a screening of that. 19 patients had invasive procedures, for example, an upper endoscopy for a submucosal lesion, and 3 out of 10,000 patients underwent surgical resection for a positive test who didn't have cancer. Of those 3, 2 of the 3 had high-grade dysplasia. And so I think we can now say that liquid biopsies or multi-cancer early detection tests can be performed in a safe manner without incurring a large number of futile invasive follow-up tests. Does this dissuade your patient from going for the colonoscopy? A very important question for us as gastroenterologists. And the answer is here. And the answer is no, it doesn't. So when you look at what these 10,000 patients, what was their uptake in terms of screening, breast cancer, colonoscopy, and lung cancer screening, their screening was above that of the national average. So as I said, this is the only currently published prospective interventional study, but over the next year or two, we're going to have a lot more studies. So the NHS has just finished enrolling 140,000 patients into the Grail Gallieri study, and we look forward to seeing the results of that. There is a trial starting in the United States in 2024, which will enroll 75,000 patients to see in a prospective randomized trial to see how it works. And then the National Cancer Institute is going to start the Vanguard trial next year, which will compare the top 2 performing liquid biopsies to see the critical question, which one is better? Liquid biopsies are also now being used for different things. So we just had the publication or the interim results of the Simplify study. So when I think all of us have patients, we have a long waiting list of patients. So how do you determine who do you need to see first? Who should you scope? So when your patients are sent to you, this was the NHS, they had 6,000 patients with symptoms. Who are you going to prioritize for that colonoscopy? And so using liquid biopsies, what they were able to do is they found that 6.7% of those 6,000 patients had cancers, and the liquid biopsies were able to detect 66% of them. So again, you can see different ways of using this. Liquid biopsies are also being used now to detect recurrence of cancer and to guide therapy. So there was a recent publication in the New England Journal of Medicine last year, which looked at stage 2 colorectal cancer. If you take a liquid biopsy 2 weeks after patients have apparently curative surgery for colorectal cancer, you can detect cancer recurrence. Those patients who are positive have an 80% chance of cancer recurrence. And that study showed that you can now guide therapy, either increase the need for chemotherapy, or if your patients are negative, give them no chemotherapy and stop it. So I think we're just at the very beginning of liquid biopsies, but fortunately it continues to get better. So I spoke about, this is a study, I showed you the results of this prospective interventional study, which used mutations in proteins. That was developed 5 years ago. We're now 5 years on. These are the new ones, which include multiple other features, such as abnormal chromosome numbers or abnormal methylation. And what you can see here is that you can improve the detection of early cancer. So you can see that with these new and better tests, You can go from 17% to 30% detection of stage 1A, of stage 1, 45 to 50% of stage 2, and overall detecting just over 60% of your cancers. So we started with, in 2023, around the world, we're going to have just over 18 million people detected with cancer. 10 million of them will die. I hope that by 2024, 25, that will change. Thank you so much.
Thank you.